Time to learn orthodontics the easy way over a cup of coffee. I'm Ji Dae-kyung, Senior Ortho Barista.
And I'm Lee Jong-kook, Junior Ortho Barista.
All right, before we dive into easy orthodontics, we can't skip our special moment of Ortho Barista. Here we go. 1, 2, 3.
커피 한잔 할래요?
It's getting better and better.
Today, we've got a sweet treat that pairs perfectly with coffee.
You know, I feel like I've been looking forward to this moment ever since the second half of the year started. Maybe even more than the coffee itself.
I'm definitely gaining weight these days. All right, today's dessert is...
두구두구두구두구두구. 짜잔. 와. 짜잔. 와.
It's Kohakuto. Kohakuto is actually called hobakdang in Korea. It's a type of confectionery made by boiling agar powder in sugar and water, then letting it cool and solidify. If you add food coloring, it looks like amber, which is why it's also called jewel jelly.
Wait, jewel jelly? Does that mean it has a slightly chewy texture inside? I really want to try it.
What are you doing?
What does this look like?
It looked like marble to me.
It kinda reminds me of an attachment. Sorry about my joke. All right, let's try. Here we go, popping it into my mouth.
뭐라고 하셨어요 지금? 네가 해야지. 웃기. 오.
The crunching sound is nice.
막 뭐가 나온다.
It's really good. It also kinda reminds me of some junk snacks.
I feel it is crispy on the outside, soft on the inside.
Crisp out, soft in?
Is that a newly made-up expression?
Come on, people say this a lot.
Really? You sound like Gen Z.
All right then, since we just called it jewel jelly, why don't we go attach the attachments that look just like it?
Let's go.
자, 오늘은
For this lecture, we've chosen the theme Clear Aligner, bonus episode.
사실 저희가 네 편
While making the 4 episodes on clear aligners, we received a lot of requests from our viewers.
시청자분들께서 치과의사 선생님들께서 많은 요청들이 있었습니다. 실제로
Many of you asked some very practical questions, almost like what we'd cover in a one-day seminar workshop.
좀 여쭤보셨죠? 그래서
So, we'll be covering these questions today. With clear aligners, the patient is the one actually wearing the appliance. For traditional braces, the orthodontist places brackets and wires and makes all the adjustments. So, what are the differences in the orthodontist's role between clear aligner treatment and traditional braces? What do you think about this?
Actually, in many lectures, we've seen numerous cases related to clear aligner diagnosis and treatment planning. There hasn't been enough focus on what orthodontists actually do in clear aligner treatment. That is why this is the part where we get the most questions. There are definitely a lot of important aspects to consider.
대표적인 거
But today, we're going to focus on just 2 key points and explore them in a practical way.
드리려고 합니다.
Now, this actually comes from a question we received during our previous clear aligner session.
분인데요.
We received a request to show how clear aligners are delivered to the clinic, so we'll briefly go over this with images.
넘어가도록 하겠습니다. 이렇게
For MagicAlign, each package contains 6 clear aligners. They are delivered in sets of 6, which make up one treatment batch.
순서 같은 것들이
Inside, you'll also find an instruction manual.
저희가 이제
This is a photo of the aligners fitted onto a study model.
그런 사진이라고 보시면 될 것 같고요. 이건 실제
And here, you can see how the MagicAlign clear aligners look when placed inside a patient's mouth.
모양이라고 보시면 되겠습니다.
The packaging looks much nicer than before.
Yeah, it's definitely been improved a lot.
키트도
And even the starter kit now looks quite premium.
것 같아요.
There's always a bit of excitement when you first receive the package, right?
설렘이 좀 있잖아요.
Of course.
What's inside matters the most.
오늘 대표적으로 이제 두 가지
And I will cover the two topics that got a lot of attention during our one-day seminar.
이제 관심을 가졌었던
One was IPR stripping, and the other was attachments and bonding.
이 두 가지 부분에 대해서 설명을 좀 드릴까 합니다. 일단 첫
First up
번째로
is IPR.
IPR 하면은
As an orthodontist, what do you think about IPR?
As you know, one of the biggest causes of malocclusion is lack of space. In this case, we choose to extract teeth to create space, or we slightly reduce the size of the teeth instead. And in that sense, IPR is one of the key techniques that secure more space, especially in the limited space of the oral cavity.
When we conduct hands-on training sessions, we often find that IPR is one of the biggest concerns for general dentists.
이제 교정의사 선생님들이
On the other hand, orthodontists seem to approach it with more ease. For general dentists and prosthodontists, I think there's a little concern or hesitation on IPR.
걱정 뭐 이런 것들이 있으신
So, to address this, we looked into several AJODO papers on the topic.
물론 이제 논문이 뭔가
Of course, research papers can't tell everything, but the ones we looked at specifically address concerns over IPR such as the risk of cavities and other potential issues.
논문들인데요. 뭐 어쨌든 결론적으로는
Ultimately, the conclusion was that there aren't any major issues associated with IPR.
있습니다. 물론 이제
Of course, excessive reduction should be avoided, but as for the optimal amount of reduction, I'd like Dr. Jankuk Lee to explain that in a bit.
주셨으면 좋겠고요.
Now, the second paper is quite interesting. It presents the differences in perspectives on IPR between orthodontists and general dentists.
생각에 대한 차이
In the end, the study identified four key conclusions.
정도 이렇게 찾아보시면
One common ground between both orthodontists and general dentists is that they generally consider IPR as a minimally invasive procedure.
이제 그에 반해서 이제 조금 더
Diving a bit deeper, the study suggests that general dentists tend to feel more discomfort about performing IPR compared to orthodontists.
또 이제 IPR을 하고 났을 때 뭐 아주 적극적인 폴리시
It also points out that after IPR, general dentists are more likely to take proactive preventive measures, such as extensive polishing and fluoride application.
논문입니다. 이렇게 이제 보실 수 있고요. 어찌됐든 이제
So overall, the conclusion of the study conducted in the U.S. was that general dentists and prosthodontists tend to have more concerns about IPR than orthodontists.
이제 결과로 이렇게 낸 것이고요.
Dr. Jankuk Lee, what are your thoughts on this?
So, if IPR is performed beyond the normal range, we should be always cautious of the potential risks. But in my short experience, though over the past 10 years, I've never encountered any major issues with IPR.
10여 년 이상 해본 경과를 보면은 크게 문제가 된 적은 한 번도 없었던 것 같습니다.
네. 뭐 저
Even as an orthodontist, I make sure to do thorough polishing and fluoride application after IPR as a preventive measure.
적극적으로 해주는 편이긴 한데요.
There may still be some controversy around the topic, but I don't think dentists need to be overly concerned.
걱정하실 필요는 없을 것 같다.
So, these are the two key points related to IPR that we wanted to highlight today. How much reduction is appropriate? How should it be performed? Let's talk about the two key aspects of IPR. This paper is about recent systematic review on the appropriate amount of IPR. To summarize the key findings, one of the most representative studies looked at proximal enamel thickness and provided general guidelines. According to this table, enamel thickness varies, but a commonly referenced range suggests that up to 30% of enamel can be safely reduced. To simplify, 4 teeth from the number 3 to the number 3, the recommended reduction per surface is about 0.2 mm to 0.3 mm. That means the total reduction would be around 0.5 mm to 0.6 mm. So, from the mesial surface of the number 13 to the mesial surface of the number 23, the available space created through IPR can be like this. As shown in the image in the premolar region, where the enamel is relatively thicker, it is generally accepted that IPR can be performed up to 0.5 mm per surface, resulting in a total reduction of approximately 1 mm.
IPR을 하는
Since the primary purpose of IPR is to create space, even this amount can secure a significant amount of space for tooth alignment.
There are studies suggesting that performing IPR to this extent could be comparable to extracting the tooth number 5. However, personally, I tend to prioritize other areas over the premolar region for IPR. The first step should always be an accurate diagnosis, considering factors like Bolton's ratio. After accurate diagnosis, 0.5 millimeters of reduction is generally considered a reasonable amount. From there, IPR can be gradually extended if needed. The reason I avoid excessive IPR in the premolar region is that it can sometimes lead to undesirable spacing later on. In particular, IPR between number 5 and number 6 tooth can pose a challenge because fixed retainers typically don't extend to the molars. As a result, after treatment, there's often an issue with food impaction in these spaces. So unless it's absolutely necessary, I try to minimize IPR in these areas. I try to postpone IPR in this case.
In a way, this is just another perspective on the same topic. Some might argue that when there's significant crowding in the anterior region, IPR can be chosen. Of course, the main reason for performing IPR isn't just to address crowding, but to improve retention after treatment since the contact point between teeth shift from point contacts to surface contacts. So, this is another aspect worth considering.
And age seems to play a role in this as well. As people get older, even if their teeth experience more wear, they often don't feel significant sensitivity, just like how the pulp chamber naturally narrows over time. Therefore, in older patients, there tends to be more room for IPR. On the other hand, for teenagers and adolescents, I personally try to keep IPR to an absolute minimum. I think it's important to always keep age-related considerations in mind. Now, as for how IPR should be done, the approach varies significantly from one clinician to another. In fact, the way I perform IPR now is quite different from how I used to do it during my residency. This is one of the most well-known clinical images from the Zachrison study, which has been widely referenced.
The Zachrison burr was incredibly popular for a while.
I actually used the Zachrison burr during my residency, but I found it really difficult to handle. It is because, for me, disc-type burrs felt a bit too risky to use. Some clinicians actually recommend using this burr, and I'm not saying it's a bad option at all. But in my case, I found that even a slight error could lead to unintended enamel reduction in areas that didn't need it. Of course, it's true that extreme caution is needed when using it, but personally, I tend to avoid disc-type burrs.
Since they lack flexibility, it's quite difficult to control the direction and amount of enamel reduction, just as you mentioned.
However, there are definitely clinicians who use them very skillfully. Those clinicians are true experts. Now, when it comes to tooth shape, some teeth have a more triangular form, while others are more rectangular. In cases where teeth are more triangular, we often need to perform more stripping and more IPR, as this can help improve their overall shape. However, this table shows that enamel thickness varies regardless of tooth shape, whether the tooth is rectangular or triangular. The thickness isn't necessarily the same. Now, as for how I perform IPR, I personally start by grinding the contact point first, and then I use strips. When grinding the contact points, I use a burr that's slightly thinner than the proximal burr commonly used in prosthetic treatments. Here's what it looks like. It's extremely thin. It may seem a bit thicker in the photo, but in reality, it's much finer. This is the proximal burr that we often use, and the one I use for IPR is just a bit thinner. So, I used to use the previous burr, but about 3 to 4 years ago, I switched to this one. The thinner the burr, the easier it is to open the contact points, so I always try to use the thinnest option available. Recently, even thinner burrs have been released. These are almost as thin as a needle. I used to think this proximal burr was thin, but now there are even thinner versions. There are several different types, but they're all incredibly thin. When performing IPR, we're usually dealing with misaligned teeth, rather than perfectly aligned ones. In such cases, the thinner the burr, the better when grinding the proximal contacts. That's why recently, for cases with severe crowding, I've been using ultra-thin burrs more frequently.
On the other hand, while we don't necessarily need to worry about it, thinner burrs do wear out more quickly.
Right, you mentioned the replacement rate, and that's an important point. You probably know this even better than I do, but since we don't use high-speed handpieces as often, the burr really needs to be almost brand new to work efficiently for opening contact points. If the burr feels blunt when you use it, it's best to replace it immediately for effective IPR. As you mentioned, the thinner the burr, the more frequently it needs to be replaced.
This means higher costs.
And another thing is that thin burrs tend to bend easily. If you use a burr without checking and it feels dull, that means it's 100% bent. You'll know right away once you try it. So, be careful with bent burrs, and if you feel like the burr is getting dull, I highly recommend replacing it immediately.
A quick way to check is to stop irrigation and run the high-speed handpiece on its own.
If the burr is bent, you'll notice it right away, so always make sure to check before using it. Now, let's take a look at a video. This clip shows the process of grinding the contact points. The key point here is that it's always important to approach from the lingual side. I'll explain the reason for that later. For now, just remember to approach from the lingual and slightly open the contact points just enough to create space for the strip to fit in. Now, here's a useful tip. Since we're mainly working in the anterior region, approaching from the lingual side means water tends to spray into the patient's nose.
That's true.
So, instead of using a mirror, I hold the burr in one hand and use the other hand to lift the patient's lip. By pulling the lip up, the water stays inside the mouth instead of splashing into the nose. For me, when using strips, it is effective to retract the lips in one hand and hold in other hand.
If you focus too much on retracting the lip with a mirror, you might accidentally press it against the cortical bone, which can be uncomfortable for the patient.
That's why I don't use a mirror for this step. So by lifting the lip, you can prevent the water splash while also maintaining a clear field of view. Now, when using the burr, it must always be positioned parallel to the occlusal plane. You should never approach the contact point at a vertical angle. If you do, you risk unnecessary enamel reduction. Therefore, it's crucial to always approach from the lingual side while keeping the burr parallel to the occlusal plane. So, once the contact points have been opened, the role of this instrument is finished. Now, many clinicians emphasize that you should never use a diamond burr for stripping, and that is absolutely true. You have to be extremely careful with it. While you could technically do a bit more reduction with it, it's best to use it only for grinding the contact points. After that, you should switch to using strips. Next, we proceed using the dental stripper, as shown here. You can use water spray or air blowing, either way, cooling is necessary during the process. These strips come in various thicknesses, and typically, the first strip to fit into the space created by the proximal burr is around 0.2 millimeters thick. Typically, we don't immediately jump to using a 0.5 millimeters or thicker strip. For example, if the order sheet specifies creating 0.4 millimeters to 0.5 millimeters of space, we usually start with 0.2 millimeters. There are different strips available based on thickness as well as grit level, so choosing the right one is important. The usual sequence might go from 0.2 millimeters to 0.4 millimeters or from 0.3 millimeters to 0.4 millimeters.
Some companies provide gauges, which can be very helpful for precise measurements.
In some cases, manual stripping is also commonly used. Back in the day, when my practice was still small, I used to do everything manually. There are still clinics that don't have engine-driven systems, so they rely on hand strips, also known as manual strippers. But this method is quite difficult. If you try to use a strip without first opening the contact points, the patient will feel a lot of resistance, which can be very uncomfortable for patients. That's why it's crucial to open the contact points first before using a manual strip. I'm sure many of you are already familiar with this technique, and personally, I call it hand stripping. When performing hand stripping, I always place a cotton roll to protect the surrounding soft tissue. Without it, there's a risk of unintended damage in lip during the procedure. Now, as you can see, using manual strips can feel very tight at first. In that case, there are different techniques, but what I usually do is secure the strip in place, apply firm pressure, and pull it out in one quick motion. Then, as stripping progresses, you'll gradually start to create space.
After performing IPR, you can also use manual strips for polishing the surface.
Using a finer grit strip for manual finishing is a good option, and I'm sure many of you are already doing this as well.
Yes, that's exactly right.
After stripping, we now have about 0.5 millimeters to maybe 2 millimeters of space. But as you can see, performing IPR in cases with severe crowding can be quite challenging. One thing we need to be especially careful about is the labial surface. It's crucial to preserve as much of the labial surface as possible. That's why we always emphasize approaching from the lingual side with the proximal burr. If you're not careful, you might unintentionally remove labial surface, especially in the middle areas. So, keeping these risks in mind and maintaining control during the procedure is very important. Alright, let me show you again. This is what the instrument looks like. Of course, different companies have slightly different designs, but this is the one I use most often. As mentioned earlier, this proximal burr is the standard one we typically set up. Here's a thinner version, and this one is a strip, which comes in various thicknesses. Various companies manufacture these, but the one I use is from World Biotech. They offer a wide range of strippers with different thicknesses and grit levels. I recommend keeping a set of different thicknesses, maybe one or two of each, so you have them readily available when needed. There are also polishing strips. As we mentioned earlier, post-IPR care is crucial. The main reason is to reduce the risk of caries. So after stripping, it's important to smooth the surface either by polishing or, in some cases, applying fluoride. So, the point I wanted to emphasize earlier is that if you approach from the labial side, the labial surface gets reduced like this. When that happens, you might notice shading on the labial surface. Even though the teeth are technically in contact, they can end up looking slightly separated. When the labial surface darkens,
it also becomes more prone to staining.
That's why I wanted to highlight it's always best to approach from the lingual side whenever possible and preserve the labial surface as much as we can.
Now, moving on to the second topic. Earlier, we talked about jewel jelly, right? That brings us to bonding for attachments. Let's talk about accessory bonding as a broader category. Here, you can see attachments already in place. Now, let's go over an effective way to bond them properly. Each attachment serves a specific function based on its shape, size, and position. But you don't need to memorize everything from the start. As you continue working with clear aligners, these concepts will naturally become familiar to you. Once you get used to it, you'll eventually reach a point where you can confidently customize the shape, position, and size of the attachments and even place specific orders based on your preferences. But in the beginning, it's perfectly fine to just follow the prescribed setup as it comes. So for now, just focus on getting comfortable with the prescribed setup and process. Whether you're using Invisalign MagicAlign, attachments are automatically assigned. Now, as you can see here, a template is provided. This template allows you to transfer the attachments that were designed on the resin or study model onto the patient's teeth. When you receive the template, make sure to check the attachment's position, shape, and size as they are listed in the documentation. Also, verify that they match the study model accurately.
These days, many clinics use 3D printed casts, which are typically resin models.
Oh, but these days, they don't always provide it, right? MagicAlign still sends the resin models, but Invisalign never did.
Actually, it used to be included, but here is the cutting line margin.
손상이 돼서
But when cutting this part, the model would often get damaged.
Still, I'd love to receive it. Now, as you can see, the template adapts to the teeth like this. We fill these areas with resin to bond the attachments in place. There are also 1 or 2 useful tips for this step. Like you see, it is bonding process. This is how to bond them. Since we apply occlusal pressure either from the patient's bite or by manually pressing from the occlusal surface, this process can sometimes cause minor deformation due to the external force being applied. So, if you press down on the gingival margin using your finger or fingernail, you can help secure the attachment properly. At this stage, you also need to blow air and ensure proper adaptation, so having an extra set of hands can be really helpful.
It's quite difficult to do this alone.
We usually have 2 staff members for this step. In fact, when I try to do it myself, my team won't even let me do this alone.
The attachment really does tend not to adhere well.
You're right.
Let me highlight this part for you. If you simply apply resin, place the template, and proceed with curing, the attachment may fall off,
그냥 큐어링을 하면 뜨게 되기 때문에
Causing air bubbles to form.
That's why you must apply finger pressure to ensure 100% adaptation. Always double-check this step to achieve an accurate adaptation.
Even after ensuring proper adaptation, when you remove the template, there will still be some excess resin around the attachments. To refine this, simply use a round burr to gently smooth out the excess material. Now, here's an interesting study related to this topic. When filling the template with resin, do you typically use packable resin or flowable resin?
저는 이제
I personally use flowable resin, and it adheres well.
I do use both types, but since flowable resin is much faster, I tend to prefer it these days. With packable resin, I have noticed that it can wear down slightly over time, so in those cases, I usually reinforce it as needed. But overall, I find myself using flowable resin more often. So, with that in mind, I looked into some related studies. The key takeaway from this paper is that there is no significant difference between flowable resin and packable resin in terms of attachment function and effectiveness. Now, let's take a look at a video demonstrating how to bond attachments. You first fill the attachment holes with flowable resin, making sure to avoid air bubbles.
One additional tip, typically, the template comes divided into 4 sections. With MagicAlign, when bonding 3 to 4 attachments, I personally cut the template into smaller sections. It's easier to ensure proper adaptation when bonding 2 attachments at a time rather than 4 all at once. If you try to place 4 attachments at once, one side might lift while securing the other, and if you cure it in that state, the accuracy can be reduced. That's why I always cut the template and bond 1 or 2 attachments at a time, and you'll get much better adhesion this way.
Ultimately, the goal is to attach them as accurately as possible. Now, occasionally, attachments may come loose from the template, or they might detach during clear aligner treatment. If that happens, you don't need to request an entirely new template for individual teeth. Instead, you can simply cut the existing template for the attachment on the affected tooth. Now, it's time to proceed with adaptation.
Make sure to store the template carefully.
And control the resin application to prevent air bubbles. Adjust the amount of resin so that excess material is minimized. And then, fully dry the area, apply pressure on the gingival surface to confirm an accurate fit, and proceed with curing. The detachment rate isn't as high as you might think.
Personally, I've had less than 5% of attachments come off. Actually, not even 1% in most cases. It's roughly around 1%, so while some clinicians may feel that attachments fall off easily, in reality, they don't come off that frequently.
So that's how you properly bond attachments. Now, let's move on to additional accessories. For example, when using elastics, we often need to bond buttons. For metal buttons in the posterior region, you can simply bond them as usual. When bonding buttons in the anterior region, I've noticed that clear buttons tend to have a high detachment rate.
Is that just me?
No, I've experienced the same thing.
Oh, so it seems like a common issue. Of course, there might be newer versions available now, but in the past, they used to fall off way too easily.
So I'd like to share a good tip that some of you might already be using. You can actually create a button using a power chain. The profile is a bit lower, but functionally, there doesn't seem to be any issue.
This method is applied when bonding a button in the anterior region. In this case, the button is used for high canines that need to be extruded, allowing elastics to gradually pull them downward. So this is how we create a custom button.
Now, if you look here, this is a lingual button, which is typically secured using an O-ring, similar to how we ligate brackets. If you want something thicker than a power chain, you can use this method instead.
Now, power chains tend to slip out easily, but when using O-rings, the resin is applied in this area, making removal difficult. If you look closely here, you'll see a cutting line, and simply make a small cut using a pin cutter and proceed with curing. Here, you can see how it detaches smoothly after cutting. So just make a slight cutting line on the O-ring with a pin cutter, and you'll be able to remove it effortlessly.
You get what I mean, right? So, when you apply resin over the button, removing the O-ring can be quite difficult. That's true. That's the issue we're addressing here. If you struggle too much while removing the O-ring, there's a risk of the button detaching as well. In some cases, I actually use 2 elastics or power chains at once, which means I need a larger volume lingual button. For situations like that, we often use what's called a separation O-ring, specifically the blue O-rings.
Some of you might be thinking that this would easily come off, but in reality, it's actually quite secure.
That's right.
It holds really well.
Today, we covered IPR stripping, as well as the application of attachments and lingual buttons, along with demonstration videos. I hope this session provided some practical insights. Thank you for watching, and I hope you found it helpful.
Among the many different techniques available, this is just one of the methods we use in our practice. I hope you see this as an introduction to our approach.
Think of it as a quick tip, and hopefully, it can be helpful for you as well. Our final broadcast of the year is officially scheduled.
We'll be wrapping up on December 20th, which means we're already nearing the end of the year.
That's right. Our last episode will be titled Retention Protocol, and we've got some fun interview clips. Some of the people we've really wanted to hear from will be making an appearance. We hope you're excited for our final episode. Thank you all for joining us today, and we'll see you next time.